I love, it's a little bit slower with the diamond, but you can see it's nice and smooth. You can really see the different colors. Now, colors and calcified teeth are tricky. What I'm looking at here, let me just tell you what I'm looking at here. So first of all, so you can see we've got a bunch of hemorrhage here. I haven't perfed. Hey, Ash here, and welcome to All Things Dentistry, the place where we're passionate about sharing those unwritten hints and tips of dentistry. Well, here's an unwritten hint already. This is the first long video I've done in a really long time, and I'm going to see if I can just let it roll unedited. We'll see what happens. So I used to use Opal Dam, and then I used to not like it because it's a resin. You'll see it come out now, and it would fall off all the time. And then I mentioned that in a video, and a subscriber mentioned just dry the teeth before you go ahead and put this on there. And I was like, oh my gosh. So I used to use Oraseal. You can see I popped a little hole in the rubber dam while I was flossing. I'm going to try to let this whole edit go, but we're going to close that up too. And so I started drying the teeth. I went away from Opal Dam, and then I went to Oraseal, it works well. Put in the comments if you use which ones you guys prefer. And the reason for these, if you're not familiar with them, is it really creates a great seal around these teeth when you're doing endo, because what happens is sometimes, as you know, some of our irrigants kind of flow over the tooth, whether it's by fluke or usually it's by accident. So then what happens is the patient tastes them, or what happens is you're about to obturate and the patient starts having saliva, or you've cleaned and shaped all your canals and all of a sudden you start to see saliva come up into your operating field, and that's not what we want. So I wanted to just kind of share this tooth because it's calcified. It's the first maxillary left molar. It's fairly challenging, and there's some tips in here that I've been using for a long time. So the first tip out of, I don't know how many tips it's going to be, this is a Zirconia crown, and what I've learned to be using for the longest time now is this egg-shaped diamond in accessing through Zirconia. And the Zirconia crown's been there for probably about 14, 15 years. This tooth was necrotic. What was it? Partially necrotic. Well calcified, partially necrotic. Oh no, it was partially necrotic. A little bit of cold sensation, but certainly percussion sensitive, aching after biting. So we elected to do the endodontic therapy. So it was symptomatic irreversible pulpitis with symptomatic apical And what happens is when you're using a regular diamond, the tip burns out all the time. But what happens is and actually this egg-shaped diamond is a little bit aged, maybe a little old. But the beauty of using this is that it doesn't burn the tip out. So as you can see here, I slipped off, if you can imagine this, it slipped off and made a little hole in the rubber dam. And I wanted to share this with you because there's our perforation in our dam. No one was injured, nothing like that. However, what I will like to do is replace the rubber dam in the middle of this, just after we get into the access, real life. So we're slowly making our way through this Zirconia crown. Let's go ahead and speed this up. We slowly make our way through that, and you can see we're not burning out the tip of our burr. And also, what happens is that then it gives us nice access, kind of flaring of the access. So what I'll do is I'm going to make my way. I'm not going to sink that whole burr, but what I will do is I'll get a certain amount into, I can't even tell you how much, till it just looks right. I'm going to make sure I do my complete access as much as possible before we dive into this tooth. Now I know, with social media today, you really want to make these ninja accesses, but I can tell you the literature still shows there's no difference in the outcomes of these teeth. And especially, I can't tell you if you're brand new to dentistry or you're even doing calcified teeth, is that having not a huge access, but a fairly more, say, traditional conservative access is going to make your life so much easier. So much easier. Okay, so we're changing out the rubber dam. That's what's happening right here. Let's go through 10 speed, 30 speed. Okay, so we're going to put our stuff back on, and off we go. Just checking to make sure that that's fully cured. Okay, so what we have here is this is our underlying core tooth structure. It looks like there was an previous amalgam that stained the dentin. And what do I do? I think I just take a regular long shank endo diamond. This is a Dentsply. I'm not sponsored by anybody. These are one of my favorite diamonds because it's got a long shank on it. And what I'm going to do is I'm going to make my way a little bit into dentin, but the intent of this burr is to kind of just finish my preparation, because now I'm not cutting with the tip of the burr, I'm cutting with the side of it. So it doesn't seem to dull out as fast, probably because now there's more water cooling as compared to the tip when you're trying to get through zirconia. So I'm slowly making my way, finishing my access, and I'm trying to keep that bevel, a little bit of a bevel. I really like having a tiny little bevel, not that I choose to do it all the time, but it seems to direct. I learned this a long time ago by listening to someone, I can't remember who it was. I think it was David Clark and whoever he was working with. It keeps that, they call it lily calyx. It sends more light down into your chamber, which is always helpful. So one of the tips, and that's what I love about having a non-standardized kind of burr block. You share burr blocks when you go into, we have a large practice, you go into different people's operatories and you're working in them, and then you find different burrs. That's what I'm trying to say. Because when you start using your own same burrs, things get boring. And then you run into a burr like this. So what this burr is, this is maybe tip number 3. This is something I've recently learned to do. And it's not only for calcified teeth, it's for especially porcelain. So this is a long shank, fine diamond ball. And this one's probably a little more aged too. But I wanted to share this with you because I usually use a diamond or a carbide to get into these teeth. But what's so fascinating about what you're seeing right now is that you can actually see what on earth you're doing. Because what I find is that, I was telling my buddy today, when you have a diamond burr, the water hits all the diamond little particles and then sprays everywhere, and your mirror's coated, and it's hard to see. And then you'll see I switch to it. I'm like, okay, well, this is, what we're doing is we're sanding. So I've learned a long time ago from our BNR rep, which is our handpiece rep. I have videos about it. He talks about the difference between diamonds and carbides. And it was so fascinating. Diamonds, you're like sanding. That's why everything's so smooth. It's like sanding. Carbides are like taking an axe and literally chopping away a dentin. And that's why they can, especially round burrs, when you take a slow round burr on clean dentin, it's just like, it actually probably sounds like that too. It's because it's like a little hatchet hacking away at the dentin. So I love, it's a little bit slower with the diamond, but you can see it's nice and smooth. You can really see the different colors. Now, colors and calcified teeth are tricky. What I'm looking at here, let me just tell you what I'm looking at here. So first of all, we are nowhere near the pulp chamber. I mean, we're close. What I'm looking here is that this is typically sclerose pulp tissue, the brownish. It's much easier you have to go between wet and dry. That's one of the most important things about calcified teeth, between wet and dry dentin. I'm nowhere near the pulp chamber, so I'm not too worried about perforating at this moment. I'm worried about perforating the whole time. But what I'm doing here is I'm actually going to switch to I think it's a number 2 round high-speed carbide burr, which I used to use for everything. And look at the shank size difference. You can see the shank is huge. The ball is actually seems to be the smallest, same size as the other one. But here what happens is you can see how it's interesting. You're actually seeing for yourself how the water sprays a little bit different around the head of that burr. And I feel it's not as controlled because this is like a little hatchet hacking away. So removing dentin is so much faster with this carbide burr. Now, carbide burrs obviously have their place in doing dentistry, and I'm not sure that in a calcified situation, it's an ideal situation, ideal instrument. So I kind of was like, I'm going to go back to my diamond. It's a little bit slower, but it gives me a little more control because I feel like I'm sanding. I completely lied. I didn't go back to it at all. That's right. So I went actually straight to a Muntz burr. So I'm running this Muntz burr. This is a purple. This is a 28 millimeter, but I found it was a little bit short. If you're new to Muntz burrs and you're starting to do more endodontics, I highly recommend you diving into getting some Muntz burrs. So I'm going to be running this, I think I remember if I said 10,000 RPM, and I'm kind of troughing around to dark spots. Yes, I'm going to have to get through this white spot. White spots are really tricky in calcified teeth because some white spots actually you need to remove. I was talking to my buddy yesterday about this. Like this white spot here, oh my gosh, what on earth is this? So let's remember what this looks like here, and then when we've got this case finished to see if it's gone. So I'm slowly kind of brushing away at these brown spots. You know, I'm kind of like, well, what's going on here? So my dental assistant washes it. I'm going to put some water on it and just take a look. Just a little bit of water. You see how it darkens everything? So here we have, this is our palatal canal, MB1, distal buccal, and, you know, I mean, stuff. So I'm going to take, I still have the short Munspur. So I'm like, well, let's take a look in the distal buccal. Let's look around there. And I'm basing my anatomy based on this crown. Now, you can't do that all the time. You got to be really careful because I've made mistakes before. And I'm just removing dentin from different brown spots. That's about it. So let's speed this up. I'm going to remove that white spot there. It's a little bit tricky. And then what I did was I saw this kind of like browner spot. Like, okay, maybe the pulp is right there. Maybe a little entry into the pulp is right there. Nope. So I'm going to do this in 2-speed. I'm just doing the same things. And this is what I'll do for every calcified tooth. So here we are. Well, actually not this. This is brand new. I started using this on zirconia and anterior, especially zirconia crowns, anterior crowns. Anterior zirconia crowns this is what I use it for. So I'm just sanding that floor, looking for any type of entry point, slowly making our way down towards that pulp chamber. Okay, we smoothed some things out. Not much of a giveaway. I know that I still have space between the furcation and the roof of the pulp chamber. I don't know. I don't even know if there's a roof of a pulp chamber. I've looked at the bite wing. There's nothing. I don't have any previous bite wings of this tooth. So what are we looking at here? We're looking at lots of dark spots. So I'm looking at pulpal. I'm looking at palatal right here. I'm looking at MB1, and I'm looking at distal buccal here. Those are the highlights I'm looking for. Usually I'll go for the palate, but in this case, I couldn't really tell where the palate was. And I see this little line right here. I'm like, you know what? That's probably something to do with the MB1. Unfortunately, it's not as clear in my mirror as it was in real life. So we're just headed towards, I'm spreading the love all around the roof of this pulp chamber, this calcification. And, one of the other options you can do is use ultrasonics. I honestly can't stand ultrasonics for doing stuff like this. I find it's too slow. It's just not as fast as round burrs. Now, you can obviously do this a lot faster, for sure, with high speeds, but I did not want a perf. Okay, so we're taking our DG16 Endo Explorer, and I had a little stick right there in that dark spot. So one of the things I've taught, and actually I had a subscriber mention that was really helpful, is I'm looking for liquid to come flying out of there. So I didn't see anything. I'm going to take another spot. And when you're in calcified dentin, calcified pulp tissue, everything sticks. You put your Explorer in, boom, everything sticks. So you're kind of like, and that's one of the reasons why I don't use, like right here, I don't use ultrasonics, because they create these little fake white spots all the time. I'm like, but look at this. See this little dot? That little glisten right there. It's so subtle. Let me back up here. Oh my gosh. That little white dot, I think, is like, hey, I think I got some pulp tissue there. I think I'm into the pulp right there. So I'm going to try to do this really slow. Yeah. So that little white dot. So you can see this looked like a kind of a track of a pulp tissue, pulp chamber, pulp canal. Yeah, you can see that little glisten. That's all I saw. And I was like, you know what? Let's give that a shot. So whenever I see that, the first thing I'm going to do is I'm going to take my Wave on Gold primary, or in this case, small, and let's see what happens. Boom, I'm in. That's it. That entry point gives me so much more confidence in my overall game. So what I'm going to do, you can put hypochlorite. I'm just going to place some water there, and I'm going to slowly make my way down into that canal. Now, this video, if you're watching, you're going to be seeing me not actually use a hand file. So that is not normally what I teach, but in the last 5 years, I've rarely used hand files. I've really become much more confident with my reciprocating files in terms of gauging just getting my working length, making its way down the canal. Now, the thing is that I'm switching out my files not quite frequently. I won't use a small more than a certain amount of times. It's more like a feel kind of thing. It's like just an experience thing. If you really want to get into that, I highly recommend you practicing on extracted teeth. That's where I practiced a lot of this technique, was extracted teeth, just going without hand files to try to figure that out. But really what I highly recommend you doing is using what you just saw there and then switching to hand files. It's not so much say what I do, don't watch what I do kind of thing. It's more of, you're watching somebody who's done this for a decade and a half, almost 2 decades of endo, and I've just come down to make it more efficient. But I wanted to share this with you just so you can kind of see what's going on. So this is now a Wave on Gold small, and you can see this is what I do here. I'm going to get my working length just using my apex locator on the top of with my reciprocating file. And I'm not going to go into actually, there you can see what I'm doing is I'm not just driving that file down. I'll tell you my whole technique right now. So what I'm doing is I'm going down the canal. See how there's lots of irrigant right here, and when I bring the file out, what's happening here is, I've seen this over and over, this is the technique I use, is that the file, because it's in a reciprocating mode, it actually drops the debris off into the hypochlorite. That is, to me, the most critical thing. I'm making sure that before my flutes go back down the canal, I'm going to go for like one pass of, say, 2 to 3 seconds. There's no pressure on it. And then I bring the file out and I empty the flutes either in a sponge or in sodium hypochlorite that's in my pulp chamber. That is the secret. And I honestly think that that's the reason why a lot of files are broken. It has to do with too much debris, the flutes are too filled with debris. I'm doing it even with my primary. Watch this. Down, 2, 3, out. Empty the flutes, back down. I'm going to my working length on this, which is 19. And that's it. So when I see broken files, not so much little short ones, not little shorties, but longer ones. So what I'm doing here is I'm going back down with my primary. So what had happened here was I wasn't able to get all the way down with my small, all the way down to my working length. So initially, so what I'll do is I'll go back with my primary. So I'm just, it's like essentially I'm enlarging the coronal portion of the canal and going back down, and then we're making our way down to working length. I'm going to take that just a hair longer, and you can see that apical tissue is really irritated. So for sure this is symptomatic apoperitonitis, and I see that, I wouldn't say hemorrhage from the PDL or that apical tissue frequently. That might be the apical, say that's the apical third of the pulp tissue. We got some hemorrhage. I'm not too concerned about that because we only have if we think about the final, so when we're doing endo is not just taking files down a length, it's also the diameter of the file that you're taking down. So what you'll see, and this is fairly consistent with what I've experienced over my career, is that once I take that to a medium, so not a small, once I take this MB1 to a medium, that hemorrhage will stop. And I truly think that what's happening is that the apical constriction, apical third, is still bigger than a 2507, which is my primary, and I really need to get something like a 35 down there. So I'm taking my primer. Actually, I don't even know what file this is. So either a primer or medium. And I appreciate you watching along. I mean, it's hard to watch endo in the first place, let alone trying to make it all the way through a case like this. So you can see we've got a bunch of hemorrhage here. I haven't perfed, thankfully. And what we're doing is we're going to irrigate. I mean, in my mind, I'm kind of like, okay, what's going on here? Am I going to be able to finish this case? What happens is that was actually my medium that went down there. Actually, that's fascinating. Let's see. So sorry, I didn't realize. So that's my medium. I take my rubber stops off if I'm trying to find working length. So I take my medium. We machine that apical constriction, whatever it is that you call it, the apical third. Let's do that to a medium. And boom. So that's a 3507. Hemorrhage stopped. It doesn't actually come back. I'll give you a secret. Okay, so you don't need to, so what you just saw me do, and that's part of your decision-making process. Do you machine this all the way down to a 30, your final size right up front? It doesn't really matter. I elected to because I'm like, you know what, I'm here. I need that confidence. I'm gonna build some internal confidence. Let's get this machined out to at least the medium. Boom, we're done. Now I can focus on the rest of the tooth. You don't have to do that. You could just get your working length. Heck, you don't even have to get your working length. But today I just decided to. I've done other cases where I'm like, okay, I don't know. We'll open this up to a small. I mean, every situation is a little bit different. So this is now very critical because, sorry, let me get this right here. So we've got our, I'm going to use this canal. Let's see, I'm trying to get it in the right spot there, guys. Sorry. So we now know that this is MB1. I can now sort of triangulate kind of where the landmarks are. So you can see now I know that this is probably leading to distal buccal right there. Sorry, I'm trying to get in the right angle. Boom. So I can probably, I mean, you can probably see it. This is going to be leading probably somewhere to a distal buccal right here, just based on the cusps, based on our angulation. And then, well, heck, we know our palate's around here somewhere. All right, so in this situation, what I elected to do was just use my purple Munzber. Let me get that out of the way. And I'm just going to trough, and I'm like, okay, that's not very helpful. I don't want to perf. Usually I put a little bit of pressure, but I'm not getting a lot of love from there. I can't remember. Let's just see what's going on here. So it's tricky, right? Like, you're kind of like, I don't know. I actually can't remember what happened here. Okay, so what happened was I wasn't feeling the love from the distal buccal. So I'm like, you know what? Let's go ahead and just trough for MB2. Let's see what happens there. Let's entertain ourselves. Right here, this. Watch with me. Yeah, watch it. This is confidence building right here. All of this white stuff. What this is debris getting caught into a groove where pulp tissue is, or else that's just pulp tissue itself. And I'm uncovering where not only is this where MB2 is, boom, booyah, this is actually the start of the rest of the pulp tissue. Let's go ahead and take a look here. Let's dive in there, friends. So this here, this lovely material, that is a huge indicator, and that is what just gave it away. This tooth literally gave away its secrets right there. So I'm going to open it up just a little bit more, and I'm like, you know what? I think I got pulp tissue. And then I'm opening up even more. That's all pulp tissue right there. Boom. All of this. Right there. I know it's hard. Oh, that's even better right there. That liquid, that kind of like glistening tissue right. Oh, pulled it away. Dang it. Right there. Let me see if I can get a really good one. Right there. This right here, it's so hard to tell on a video screen, on your phone. Maybe you're watching on your watch in 2075 when you're watching this. But this, maybe robots will be doing this, but this right here is pulp tissue. That is like juicy pulp tissue. And when I see that, I'm like, you know what? There's enough space in here to get my endozebra. Oh yeah, I got my Explorer. That doesn't really do much. I'm like, there's enough space here. Let's give this a shot. It may not work, I'm not sure, but let's speed this up and let's go ahead and get our EndoZebra. And what we're going to do is that end of the end of this, let's see if I can bring it out if you've never used this before. No, so I'm going to slowly down, sorry guys. Right here, this is a non-cutting tip. So I'm going to run this along the pulp chamber floor. And I'm going to drive that literally right to the palatal canal. Let's go ahead and see. It's tricky. This is a very tricky burr to use. It's amazing, especially in open chambers. You have to be careful though, because you can cut dentin if you know, like, oh, I think I'm not cutting anything with because the ball is non-cutting. Well, I've thought that too, and I've cut a nice groove into something. So look at that. So this is, in that whatever seconds, this is all pulp tissue leading to the palatal canal, and boom, our little friend right there, MB2, hello. Amazing. So I don't normally do that, but I was like, you know what, let's just do it. And then I'm like, hey, maybe I'll get some, let's go ahead and see how this all works out. So I'm going to use this towards that distal. I'm going to see if I can get a little bit of traction along the pulpal floor. Again, got to be careful because you can cut. You'll rarely cut porcelain with this bad boy, but you can cut dentin pretty good because you think, you're putting pressure against something like, it's not cutting because the tip doesn't cut. Well, the sides do cut, so just be careful. So I'm just trying to groove into where that MB2 is, and let's go ahead and see what a result is. Oh, palatal canal. Oh, amazing. Palatal canal, looks like we're making our way into distal buccal, and behold, the gem of the maxillary molar, the MB2 canal. We have unlocked all of the secrets with that one burr right there. Boom. So it wasn't even there. And so, I mean, give this a shot. I encourage you to do all of this stuff on extracted teeth. Okay, so we're just going to open up that MB2. Let's do this a bit smaller with our purple months. I'm trying to see if maybe there's an MB3 here. Let's get greedy and see if we can find a few more for the folks at home viewing. And then I'll open up distal buccal just a little bit. You can see there's a little bit of a fin of tissue right there. See that? My glove's in the way. Sorry, guys. Yeah, so there's this right here is all pulpal tissue. We're deep diving down distal buccal. Sweet. Or as my kids would say, sick. They would never say that about teeth. Even though my oldest is actually thinking about being a dentist, I'm kind of like, I don't know. I don't know. Put in the comments below if you would ever advise your kid to be a dentist. I have never. They know I do this stuff. But kind of like, I don't know there, bro. Okay, so palatal pulpal tissue is hemorrhaging. So let's go ahead and tackle that. To keep this video shorter, I've skipped finishing, cleaning, and shaping the palatal canal and the distal buccal. Those are all done. They're no different than the mesiobuccal canal. It's all the same. The only difference is that what I've done is I've opened up the palatal canal to a large, so 4504, and I've opened up my two buccal canals, mesiobuccal and distal buccal, to a 3507. And now is what we've been waiting for. Let's go ahead and tackle that mesiobuccal 2. So you can see it kind of like right here. It's not in focus. I sincerely apologize. And what we're going to do is we're going to use a brand new short, should be brand new, short, oh, it's not new, so roughly new, short wave and gold yellow. So I'm going to, this is essentially right here is what I want to share with you all the time, is that I'll do 1 second on, I'm going to pull that file out, see the debris on the flutes, very important. It's going to pop off, it'll drop off, my mirror moved. When it goes back down into the canal, there's no debris in the flutes. It'll come back out, drop off, I'll shake it, you can see there, back down. So what you're seeing is, I just kind of figured this out just by doing thousands of these canals, is that the reciprocation, what I'm doing is I'm shaking it there. You can see the motion of me kind of shaking the file. So as long as there's irrigant going with the canal, I mean, it's just like a motor and engine oil. There's engine oil all the time before, unless it'll seize up. So irrigant going down with the file, and then I'm emptying the flutes in the actual irrigant itself. So what this does is it makes this procedure more efficient rather than me continually taking the file out, cleaning it on a sponge. This is so much more efficient to make my way down tight canals and whatnot. So then we're going to, I know the working length of the MB1. So roughly one of the tips, I don't know what number we're at, is that if I suspect, and it's hard to know whether or not MB2 joins MB1, who knows? Sometimes at this point, if I suction the irrigant back, so if what I just did there is I pulled back on the syringe on my irrigation tip. You can see how the irrigant disappeared right here. But sometimes what will happen is that my irrigant will disappear in MB1, and it did not. Now that is not always true because there might be they might be connected. However, there might be some tissue still remaining. So what I'm going to do now is the pulp chamber is empty of irrigant, and I'm just going to try to get a better working length. So you can see this has still got fluid in it. I'm checking to see if the fluid's gone. Now I did go down this canal once with my Wave and Gold yellow. I'm going to what I'm trying to do right there, I remember doing this, is I'm emptying the flutes in the irrigant, and I'll go back down. I'm trying to take a little bit of irrigant down the canal with me. See how there's irrigant with me? Because once I rinsed the pulp chamber, there was still more irrigant in the palatal and MB1 canal. So I'm trying to use that to empty my flutes and take the file back, take some irrigant back down the canal so I don't fracture my file. But I'm also looking, so that's one thing, emptying debris. And now, because I'm getting closer to my working length, I'm looking to see if it's cutting at the apical third. Now, if I've been burned many years ago about trying to figure out working lengths at MB1, MB2, I'm not going to get into the story, but short story right up front is that if MB2 does not join MB1, it's typically a millimeter shorter. Take that as one of the most important tips of this whole video. Because if you're having a hard time trying to get a working length at MB2 and you cut it the same length as MB1 and they don't join, it's likely going to be over prepped. And it's just a simple fact that if you look at the cross section of a root, the say for example, MB1 is at the tip-ish, MB2 is typically going to be down the mountain, if you may, on that root tip. Okay, so these two canals do not connect. They're not confluent, if you may. So we're going to irrigate both canals. What I'm going to do now is I'm going to clean and shape MB2 to a primary. I guess it's 20. You can see I'm just using, and that's the other tip that I learned many years ago, is just use the markers on your file so much quicker. You see you get a little bit of hemorrhage there, a little bit of tissue. Right there, boom. A little bit of tissue coming up, so we'll see what happens when we irrigate. A little bit of hemorrhage there, but then it disappears. Okay, so I aspirated my irrigant from the MB2 and it did not disappear from MB1. So I'm kind of like, okay, well, still, I'm not convinced they don't join because maybe this is just tissue all the way down and it still hasn't been debrided. However, still hard to tell. MB2, MB1. Okay, so let's go ahead and try our... So actually, that's another tip. So what happened was, this gutta percha point was just a little bit short. So what that tells me is that there might have been debris knocked from when I was cleaning and shaping any type of canal. So what I'm going to do is take my medium back down to length, clean out the debris, and look, a little bit of pulp tissue right there, a little bit of pulp tissue on my flutes. You can see it right there. So let's run that back down. A bit of pulp tissue there. And sometimes what I'll do is I'll use the flutes to clean between little isthmi, if you may. So let's go ahead, and what we're going to do now, this is what I love to do. It's negative pressure irrigation. It's really simple. Rather than activating my canals, what I do is I'll use negative pressure. It does multiple things. It pulls the irrigant down to the apical third, but it also removes any debris. And because this is a larger tip, the tip on this is much larger than the tip of my file. I've practiced on clear teeth multiple times to see that I need to be around 4 millimeters away from the apical constriction to still get exchange of irrigant all the way down to the apical, to my constriction. So what am I saying? I prefer this technique for sort of activating my irrigant, if you may, rather than using an endoactivator and whatnot. So the other thing that I'll do is we're going to run a bunch of sodium hypochlorite. Sometimes there's no suction, and then boom, there we go. So what I'm doing here, the last thing I'll do to try to see if I can get rid of the tissue, if there is tissue between these two canals, is I'm going to run irrigant between, it'll just suction the irrigant between the canals as well. It'll suck it out. So I'm not getting any tissue removed from those two canals, from between the canals, so it gives me a better feeling that they're not joined. At the same time, I'm still irrigating all my other canals. We'll run that irrigation tip in all the canals. One of the syringe that you saw before was actually EDTA. So I'll run 3 to 4 millimeters of EDTA. Albeit, honestly, and again, you've made it to this part of the video, I don't actually see a benefit. I don't theoretically understand the benefit of EDTA in a vital tooth, and that's what this was. It was sip-sap, because the intent of EDTA is to open up the tubules so sodium hypochlorite can get into the tubules, but that's more to kind of like kill bacteria. Not a lot of bacteria in this case. Okay, so now we're down to length. So the next thing what I'll do is, just for a little remainder of activation, is I'm going to do manual dynamic activation, which is just pumping my gutta percha point in the canals. So a little bit of hemorrhage there. I'm a little bit concerned about that, but what I'll do is I'll irrigate. I think that might be, sometimes, it just happens. Maybe there's a little bit of PDL irritation. So you can see there's more. So what I'm doing here is, when I see that type of hemorrhage, what I'll do is I'll put this to length, and kind of like, when you get cut, the first thing you do is you put pressure on the wound. I'm putting pressure here for a few seconds. So this might be problematic. So we'll see afterwards. So I'm going to pump that cone. Now, it's really critical to be very careful, because I've been burned with this technique before. I'm going to be very careful when I'm pumping that cone, depending on where I am. Like this palatal canal, I'll be very cautious about pumping it, just nice and light, just a few times, not too many times, because we don't want to pump irrigant, because we're doing essentially a fixed cone into another fixed cone, the preparation. Not a lot of room for irrigant to move around. It might go out the end. So gotta be very cautious. It is an effective technique. I've used it, checked it on clear teeth with debris, and it's very effective to remove debris. And what we're trying to do is we're trying to literally just get the debris at the apical portion into solution, so like when we irrigate it, when we can irrigate it and remove it from the apical portion of the canal. That's the biggest issue. Okay, so here we are. We've got our prepared canals. There's our MB1, MB2. Got our distal buccal, and we've got there's our distal buccal, and then we've got our palatal friend right here. So we've tried inner canals, and that's kind of what you're watching is kind of an irrigation flow, workflow to maximize efficiency. So we've cleaned and shaped 4 canals. We've got the buckles, mesial buckle 1, distal buckle machined to a 3506, which is a wave and gold medium. And what I'm doing here is I'm placing all my paper points, and then I'm blowing air onto them horizontally across the pulp chamber. And what you'll see is that helps to dry the pulp chamber. Only a little bit of hemorrhage on that mesial buckle too. So let's go ahead and recheck that. What I am doing is I'm making sure I'm not overextending my paper points. 18, 20, 22. Sometimes, depending on my confidence in terms of my working length, I'll reconfirm. I have multiple videos about talking about reconfirming working length with paper points. And then, so back to the sizes, our mesial buckled MB2 is a 2507, and my palate is a 4505. Now you may say, wow, those are really large sizes. And I'll say, clearly, I don't want this case to come back. I want this to be successful once. So we've machined the internal aspect of those canals to a good size. We've got lots of irrigant down to the apical third, and we've cleaned and debrided it. You can see it here. So I'm going to, all of these little things are just increasing my confidence that we'll have success with this tooth. Now, for sure, I was looking at some Facebook posts that just popped up where they're super skinny little preparations, and certainly they may work. But those are, I was thinking about talking about this. So just on another note, I'm just going to place my PC sealer into the coronal portions of my canals. I'll kind of push it down a little bit. You know, I think about Wave and Gold is such a great file. It's simple to use. It's really predictable. I'm not even paid by them. I've just been using it for over 10 years. I've broken maybe 1 or 2 a year, and I'm pushing them quite a bit. As you can see, I don't even use any hand files anymore. When we start to get those really skinny files and trying to place gutta percha points, you know, you got to be really expert, almost like an F1 racer. Like I consider myself, in terms of endo, I consider myself kind of like a minivan driver. I used to have a minivan. I got 4 kids. And I kind of think about endo in my hands is kind of like I'm driving a minivan, you know, like an endodontist who's done, you know, 30,000 cases. I've probably done like 15, 18,000 now. You know, that's like an F1 racer. So I'm not driving an F1 car to work. I'm not driving one ever. So that's when I see those really skinny little preps. They've got such a better handle on what's going on in terms of skill. But I always wonder, like, is that enough to debride the apical third? I'm not sure, without gentle wave or lasers or whatnot. Okay, so what we did is okay, so this is something, now you're even further in the video, so I want to share this with you. So we took our cone fit radiograph. I wanted to add I wanted to pump a little bit more sealer down the canal, and we are at 49 minutes of treatment time. So it usually takes, after I anesthetize, I usually have around 5 to 6 minutes of just kind of waiting for it to kick in, and then reconfirm with cold, and then we're good to go. So it's been like 53 minutes. I don't know, let's say 54 minutes. And as I was placing that cone back down, the patient felt pressure, and it was like, oh, and that's why this cone looks like this, because I had a little bit of shock because I was placing the cone down, placing the cone down, and then he moved. He was like, boom, that one. And then I pulled it out. He was like, ooh. He's like, no, it's okay. It was just a little bit of pressure. So that's just something that it happens once in a while. That's pretty infrequent, but we've got to make sure we've got solid anesthesia. I've got 3 carps of articaine for this case alone because it's sip-sap. I want to make sure it's completely numb. You may say, oh my God, I can't believe it. Yes, that's what I use for my anesthesia because I don't want to be... Put in the comments below if you know what I'm talking about when the patient starts feeling things, or if you're a patient watching this, you know what it's like to start feeling something during the dentist. And I know that feeling personally when I had some onlays done. So what I'll do in this case is I'm going to cut the gutta percha cones right at the access orifice at my portal into the tooth. I'm using a very large heat plugger tip. This is an 8-teeth plugger. I've been using it for 6 years now straight. I've only burned out one tip. It was a skinny tip. It died, so I'm waiting to get it a replacement. And it's just a phenomenal electric heat device. Now, I've had a question by a viewer, great guy, and he was wondering if he should move from the flame to using a flame, and that's what I went to dental school with, was a flame for heat. He was wondering if he should go to that, stay with that because of the cost of upgrading to like a woodpecker or something like this. And I was curious. Again, you made it to this point in the comments or in the video, so put in the comments below if you had that question. Should I go with the flame? And say, for example, you switch to the electric. Was it worth it? Say you're only doing maybe one root canal a week. Was it worth switching to electric, cost-wise, or efficiency-wise? Because I remember doing backfill with little pieces of gutta percha cut up, flaming it, and then putting it into the canal. I mean, it's crazy. For thermoplastic backfill technique, that was really old school versus it was the prelude to continuous wave condensation by Buchanan. We did it really old school. Okay, so I'm just burnishing like Dr. Nasei suggests to do. And then I'm going to take a high volume water rinse. We're going to rinse all that out, and then we're going to place our core material back in, just a composite back into our access. We'll etch, bond, and then layer you can use a core material, you can use whatever you want. I'm using just regular etch, and then I'll be using Scotch-Bond Universal, which has MDP because it's zirconia crown. Okay, so there you can see there's our MB1, MB2. I've just joined them in our obturation. There's our distal buccal. This little catch is just a little bit of a calcification. I checked it out after. And then there's our palatal canal. Place our etch. You don't need to watch this. We're going to scrub our bonding agent. Let's go ahead and do this at 5 times. We'll finish this off. I'm going to thin it out. We'll light cure. Place our first layer, cure. Second layer, cure. And when you see that brush in there, I'm just making that layer nice and flat. And then there's our third layer. Okay, so thank you so much for joining me in this video. I sincerely appreciate you making it all the way to the end. Let me know if you have any questions. I'll answer them in the comments. Hopefully that helps. Cheers. And then when we've got this case finished, to see if it's gone. Hey, Ash here, and I wanted to take a second of your time just to introduce our course, Root Canal Like an Endodontist. We've had it for a couple years, and we've had some amazing successes through it. Just confidence building on behalf of our students. And really what happened was, a few years ago, I wanted to create a course to help others because I know what it's like on your endo journey. A lot of times, you don't know what's going on. You don't know if you've ledged it. You don't know what to do if you blocked it. You don't even know if a curved canal, what to do. And what I wanted to do was take all my mistakes and my training from my residency and put it into a affordable online course for everyone around the world to join in. And it's been absolutely amazing. And I wanted to offer to you, check us out at allthingsendo.ca. Once you join the course, you get access into our private Facebook group where all of us answer questions. And I'm telling you, there are questions every day that you might be able to, I'm sure you'll be able to connect with, because sometimes it just takes a little bit of courage to ask a question and then your outcome may be incredible. Anyways, I look forward to seeing you there. allthingsendo.ca. We'll talk to you soon.